Okay, so the topic of lecture one is how psychologists define abnormality, or psychopathology, as I prefer to call it, because one of the themes from this whole class is that psychopathology is really not that abnormal. Some disorders like depression and anxiety are super common, with a prevalence of somewhere between 40 and 60% of the population meeting criteria for these disorders at some point in their life. So depression and anxiety, can't say that they're abnormal because they are so common. And even other disorders like schizophrenia or OCD or anorexia nervosa, which are a lot more rare than that, the symptoms of those disorders still exist on a spectrum, and everyone is somewhere on each of these spectrums. So there's really no symptoms of psychopathology that are completely abnormal, that are outside the range of normal human emotions and behavior. So rather than calling it abnormal psychology, in this class, I'm going to refer to it as psychopathology. So how do clinical psychologists like me study and treat psychopathology? People with a cognitive behavioral orientation, which is most psychology researchers, think of psychopathology as essentially boiling down to any problem that's related to someone's thoughts, emotions, and or their behaviors. And we see all of these things as very intertwined and interconnected. So our thoughts influence our emotions, which influence our behavior, which influences our thoughts. So for example, the way that we interpret events that happen to us, whether we interpret it optimistically or pessimistically, influences our emotional response to those events. Our emotional responses to those events, whether they are negative emotions, neutral emotions, or positive emotions, influence the behaviors that we're likely to engage in response to those events. And our choices and behavior influence the situations that we find ourselves in the future, which in turn we interpret through an individual lens. So that's kind of the cycle of how thoughts, emotions, and behaviors interact. And psychopathology is a problem with any part of that cycle. But typically, because they're so interconnected, if someone is experiencing difficulties with one of these areas, they're going to be experiencing difficulties in all three. Okay, so in this lecture, I'm going to talk about the 5 Ds of psychopathology. And this is kind of like a shorthand way of remembering how we draw the boundaries of psychopathology, how we determine when someone's thoughts, behaviors, or emotions are problematic. So the 5 Ds stand for deviance, danger, dysfunction, distress, and duration. In terms of classifying emotions, thoughts, and behavior as pathological, one question we do ask is, does this thought, emotion, or behavior make sense? Is it a quote unquote logical or normative or typical or helpful response to events that are happening to the person, or does it make sense within their culture or their social context? So for example, knowing about someone's cultural context can give you a sense of what their customs and norms are. Being naked at a nudist resort is very different than being naked in class, even though the behavior, not wearing clothes, is the same. The context really matters. Knowing about someone's belief system can matter too. Someone speaking in tongues who's doing that at a church revival is engaging in a behavior that's within their belief system and that's normative for their culture. And that's very different than engaging in that same behavior in any other context. This picture is another example of that. This was taken in the really early days of the COVID pandemic, when people were trying to protect themselves, but masks were not yet in common use and were kind of in short supply. So in any other context, walking around with a water bottle on your head would be quote unquote deviant. It would be unusual, abnormal. It wouldn't make sense. But in this very specific moment in time, it made perfect sense. So we wouldn't consider this deviant behavior in that context. Another way of thinking about deviance is thinking about quote unquote average behavior. So like I was just saying, most symptoms of psychopathology that we study really just represent extreme levels of typical, normal, average ways of thinking, ways of feeling, and ways of behaving. One kind of quantitative way that psychologists try to define what is average and what is normal is the use of standard deviations. A standard deviation is just a measure of how widely distributed people are around a population mean. So if the population is distributed normally around the mean, with half of the people falling on one side of average and half of the people falling on the other side of average, that means statistically that 95% of people are within 2 standard deviations of average. So we can basically, this is not a statistics class, so basically we can think of someone who's within 1 standard deviation of average is basically the same as other people. They're essentially average. And this is where most people fall in a normally distributed trait or behavior. People who are 1 standard deviation outside of the mean definitely experience that thought, emotion, or behavior either more or less than the average person. And people who are 2 standard deviations outside the mean, which again is in a normal distribution, a minority of people, are definitely different from average. So for example, if we think of this spectrum as a trait like how trusting you are, how much trust you place in other people, someone who is a little bit 1 standard deviation away from average level of trust, we might describe as like trusting. It's something that's noticeable about their personality. They're more trusting than other people. Their level of trustingness is higher than average. And then similarly, or sorry, not similarly, someone who is even farther away from average, so say 2 standard deviations away from average trustingness, we might say isn't just trusting, they're more than trusting, they're actually gullible. And this is the point where being more trusting than average might start to become problematic. There is nothing necessarily pathological about being trusting, but being gullible can lead to problems in your life. Similarly, someone who's 1 standard deviation away from the mean in the other direction, we might see as relatively suspicious, relatively untrusting. Whereas someone who's 2 standard deviations away from average trust in other people, we might actually start to see as paranoid, which again is far enough away from the average level of that behavior or experience that it's very or relatively uncommon and probably problematic. So the symptoms that we're going to discuss in this class, all of their distributions are different. Some symptoms will have a more narrow distribution where most people in the population are pretty close to average and people at the extreme ends are very rare. That's, again, symptoms of things like schizophrenia, obsessive compulsive disorder, anorexia nervosa, these relatively uncommon forms of psychopathology. Other symptoms are on a much wider distribution where the standard deviations away from the mean that someone can be are a lot wider. So someone can be relatively farther away from the average level of those symptoms, but still be considered quote unquote normal, not deviant. So as an example, a symptom of schizophrenia, like experiencing hallucinations, that's a very narrow distribution because the average person doesn't hallucinate at all and doesn't really have any abnormal sensory experiences. It's rare to have these things, so most people fall really close to the average, and the standard deviations are very small. On the flip side, anxiety has a much wider distribution. So the average level of anxiety, or people who are on either side of the average level of anxiety, either relatively calm or relatively anxious, there's a lot more of them. And so that distribution is a lot wider, and correspondingly, the levels have to be a lot higher before we would say that someone is abnormally, pathologically anxious. So to summarize, we can kind of think about deviance in 2 ways. On an individual level, we can take a look at a person's life experiences, their social context, their belief system, and ask if their behavior, thoughts, or emotions are typical, expected, appropriate, given the context for that person. When we're looking at groups of people, for example, when we're doing research in large samples of the population, the way we define deviance is a little different. And here we just ask, is this behavior consistent with the way a quote unquote average person behaves? And to quantify that, we might ask how many standard deviations away from average a person's thoughts, emotions, or behavior fall. So that's deviance. That is one of the 5 Ds, one of the ways that we define psychopathology or abnormality. The next one is danger. So does the thought, emotion, or behavior put the person or others around them at risk? For example, some forms of psychopathology are very dangerous. anorexia nervosa is one of the most deadly forms of psychopathology. One of the ways that people can be harmed by anorexia nervosa is extreme malnutrition, which can cause damage to all of your organ systems. Hoarding disorder can become dangerous when someone lives in unsafe conditions. Substance abuse disorders can become dangerous when someone is at risk of overdosing. When a thought, emotion, or behavior puts a person or other people at risk, that's a pretty good sign that it's quote unquote abnormal, pathological. The next D, the next way that we define abnormality, psychopathology, stands for dysfunction. And you might hear me sometimes call this psychosocial impairment. That's maybe the more technical term that clinical psychologists and researchers use to describe this. But basically, we just ask, is the person's life being negatively affected in some way by the thought, the emotion, or the behavior? And we break this down into kind of 3 different categories. So is it getting in the way of their social life? Is it causing them problems with making or keeping friends or with interacting with their peers and doing age-appropriate things? Does it interfere with the person fulfilling their roles in their family system? Is it getting in the way of them meeting the expectations of a parent or a spouse? Or in some cases, does it cause problems not necessarily just for the person, but for other people in the family system? And then lastly, occupational dysfunction just refers to whether the thoughts, emotions, or behaviors are causing problems with someone's performance at work or at school, so their job. And lastly, and kind of most importantly, in a lot of ways, is distress. So does the thought, emotion, or behavior bother or upset the person who's experiencing it? There are some disorders that we'll talk about, like bereavement, when you lose someone you love, experiencing a trauma, or having a phobia, being really afraid of something, where we would ask a second question. Is the distress caused by the thought, emotion, or behavior disproportionate to the situation that's causing it? Many psychologists would be hesitant to diagnose someone with depression in the wake of the loss of their parent or spouse, for example. And we don't diagnose someone with post-traumatic stress disorder until 6 months after they've experienced a trauma, because it's typical, normal, and proportional to experience many of the symptoms of PTSD in the immediate aftermath of a traumatic experience. But for most things, distress is actually one of the most important ways that we diagnose a disorder. And in many cases, the symptoms of psychopathology aren't necessarily dangerous. So for example, having a phobia of snakes. In most situations, that wouldn't cause any danger to a person or the people around them. And regardless of how extreme a person's fear of snakes gets, or how much dysfunction it causes in their life, if they're not bothered by having that fear, by having that emotion, they actually don't meet criteria for having a specific phobia. So distress is really important. There's very few disorders that we can diagnose if the individual experiencing them doesn't endorse being distressed. The exceptions are things that are objectively dangerous, like anorexia nervosa and substance use disorder. So distress is, not surprisingly, the most common reason why people seek a mental health diagnosis. It's closely related to dysfunction, because if your thoughts, emotions, or behavior are getting in your way of functioning in your life, that's also likely to cause distress. And like I said, it must be present in most cases to diagnose someone with clinical psychopathology. Okay, so the last D stands for duration. So as I said, almost all of the symptoms that we're going to talk about in class are really just extremes of normal experiences. Even something that might seem relatively rare, like hallucinations, really is just an extreme of normal human sensory perception. Many of these experiences, even at relatively extreme levels, can happen to anyone. And we wouldn't necessarily consider that pathological if it was relatively short-lived, if it was a one-time thing, if it happened once and went away on its own. So duration of symptoms matters. In most cases, symptoms have to be present for a specific amount of time, which varies across diagnoses, in order for us to diagnose someone with that form of psychopathology. So for example, depression. In order to be diagnosed with major depressive disorder, you have to have 5 of the 9 symptoms of depression, and they have to be present for at least at least 2 weeks. If you have 5 out of those 9 symptoms of depression, but it only lasts a week and it goes away on its own, generally we would consider that normal sadness and not likely due to a pathological mechanism, and so not diagnosable as psychopathology. So that's really all I wanted to discuss in this first lecture. The reflection post refers to this lecture and to the reading that will give you kind of a brief definition of each of these ways of defining psychopathology. So the important takeaways are that culture and context really matter in our determinations of what is abnormal and what is pathological. So deviance is really dependent on the norms that a person lives with, the norms of their culture and the norms of their context. And pathology really depends on, in many cases, whether the person feels negatively impacted by the thoughts, emotions, and behaviors. So the 5 Ds are deviance, danger, dysfunction, distress, and duration. And you're going to be using all of those criteria in the reflection assignment to try to determine whether people described in clinical vignettes are actually experiencing psychopathology. All right, that is it for the first lecture.